We have considered that CAR T-cell patient should be admitted in the ICU as early as any hemato patient, which is, in our opinion, very early during course of acute illness. In practice, patients experiencing CRS stage 2 or neurotoxicity stage 2 are considered for ICU admission very early. The rationale to admit this patient early is that patients with CRS stage 2 do have in practice fever and hemodynamic instability. They are basically sepsis patients, and in septic patients, our experience and the literature, even though this literature is based upon low-level evidence studies, suggests early admission to be beneficial. So we have considered that any patient with fever and requiring fluid infusion for hypotension should be admitted to the ICU, and this is the standardized procedure in our ICU. Since patients with confusion and patients with hypotension requiring fluid infusion are admitted, it's quite early as regard to usual ICU admission criteria. I don't know if we should be more early and admit patients at high risk of severe CRS, patients with very high fever very early during course of CRS, but so far this is our procedure, and in practice it was useful to have early ICU admission since patients with CRS stage 2 uncommonly have a very quick disappearance of symptoms. Usually they experience clinical deterioration, and if we don't admit this patient, and some patients were admitted a bit late as regard to our procedure, usually it's very late during course of a CRS, so we believe it's useful for the patient to be admitted early. In our hospital, in our institution, and I think it's nearly the same in a lot of institutions, there are several units and several physicians involved in patient management. Not every of them have experience of CAR T-cell patient, and in our experience, it happens that some patient with fever, having recently received CAR T-cells, having criteria to define CRS and CRS stage 2 or 3 be misleadingly considered as a sepsis patient. I don't think it's a bad thing. I think some patients with severe CRS do have sepsis and bacterial infection, but probably tocilizumab and even steroids might be considered in some of these patients. And without a procedure to homogenize practices, the risk is skipping some mandatory steps in managing these patients. I don't think we should blindly follow the procedure. Nevertheless, it has been created, it's followed, it's always discussed. There are some situations where we don't follow the procedure, and for example, some patients are included in protocols, and de facto we follow the protocol when it comes to ICU admission and management of a CRS. Nevertheless, it's a good thing to have some standardized procedure to help both training people, giving some advice in managing these patients, and having a group of patients managed homogeneously over time in a single institution. So I believe this is something that is more a guidance than something that is unmodifiable rule, but it's useful in our daily practice to have this procedure written.